Okay, well, welcome back. And again, I want to thank everyone for joining me today. My name is Dr. David Kanashko. I'm the Director of Education and Training. I'm a chiropractor, also trained in traditional Chinese medicine and acupuncture. I've been with Meditech for over 10 years now, in the capacity as a clinician, as well as obviously research and education and training. So today's webinar is on laser therapy, or what is now officially known as photobiomodulation for carpal tunnel syndrome. Just a reminder that the webinar is always recorded and that you can watch, if you have to leave early or you want to watch it again, you'll be sent a link to watch it, usually in a few days after the original broadcast date. The reason why I chose carpal tunnel syndrome is that we've been seeing quite a few cases in our clinic, and I know many of you out there oftentimes will see, the beginnings, mild to moderate cases before sometimes they need surgery. So a lot of the research and what's out there, there's some conflicting research, but the consensus is that it's very helpful for the mild to moderate forms of carpal tunnel syndrome. So be aware of that when you're seeing patients. And the goal of today's webinar is obviously a basic review of the anatomy. I'll go over the epidemiology, a bit of the etiology, symptoms, and diagnostic testing. Again, a review for everyone out there. I know you're familiar with this. And then I'll talk a bit about the research. I've chosen a few good articles to review and a few good clinical pearls in there as well. And then I'll specifically talk about how you would use BioFlex equipment, the software, and the protocols, and some techniques to improve your efficacy when treating patients with carpal tunnel syndrome. So again, if you have any questions as we go along, just type them in and I will get to them at the end of the webinar. Of course, we all know where the carpal tunnel lies in the volar aspect of the wrist. Now, if you look, just as a review, remember that the median nerve actually lies fairly superficial within that carpal tunnel. So it's actually fairly easily accessible with laser therapy. And if you're new to laser therapy, some of you may not be aware of the depth of penetration. Of course, that is determined by the wavelength mostly. Red being relatively superficial, a few millimeters kind of thing, 4, 5, 6, 7, 8 millimeters, and near infrared penetrating significantly deeper. But of course, the effective depth of penetration revolves more around how much energy is entering into the tissue and for how long, right? So the key thing here with the carpal tunnel is that it's relatively accessible, and we know that there's a huge amount, an abundance of research to indicate that photobiomodulation is very helpful for nerve regeneration, nerve repair, and improving conduction velocity. So it makes sense that this should be quite effective, or at least one of the tools that you would use when treating carpal tunnel syndrome. It is one of the most common focal peripheral neuropathies. Obviously, it results from compression of the median nerve, specifically in that tunnel. It tends to be more female dominated in the ratio of 3 to 1. The thinking there is that it may be due to the size of the carpal tunnel being narrower in females than males. It is most common in people who perform repetitive movements of the wrist, which makes sense. And the prevalence overall is about 45% of the general population. So when you think about it, it's actually significantly high, just because people are using their hands and their wrists on computers so often now. So it's one of these things where you can use this effectively as a tool. You have to educate your patients and make sure they come in at the first signs of the symptoms. Idiopathic form is the most common form, excuse me, and it can be bilateral. Up to 50% of cases can be bilateral. There can be hypertrophy of the synovial membrane of the flexor tendons, and this can cause degeneration of the connective tissue and causing vascular sclerosis and swelling, edema, and breakdown of collagen as well. The research indicates that if you're a patient or if people are at a computer for less than 15 hours a week, there's not necessarily any increased prevalence. However, as soon as you get over 20 hours a week, which I think most people are, then there's definitely a correlation with increased prevalence. Other causes or known etiologies are abnormal anatomy, congenitally small carpal tunnel, obviously. Sometimes ganglion cysts or lipomas can cause the compression. Obviously, traumas, sprains in the wrist area, types of infections, septic arthritis and Lyme disease. Certainly any inflammatory conditions causing edema like RA or tenosynovitis or even gout, although it's fairly rare in that area. And of course, we're all familiar with it being an increased prevalence in pregnant patients. Usually that's a temporary kind of scenario. In obese patients, hypertension, and edematous patients as well. And it can be linked to metabolic disorders like diabetes and hypothyroidism as well. So in the early stages, the sensory fibers are more susceptible to compression than the motor fibers. So you tend to see paresthesias and some pain that predominate in the early stages of carpal tunnel syndrome. Nocturnally, there will be intermittent symptoms. The patients will start to feel some pain and paresthesia, obviously in the distribution of the median nerve. As a reminder, you can see on the right where the distribution lies. And of course, we're all familiar with that. Symptoms can vary widely and occasionally localized to the wrist or the entire hand. And you will find some patients complaining of radiation of pain up into the forearm and even sometimes up into the shoulder. So be aware of any double crush syndromes going on. Make sure you assess the patient's cervical spine as well as a shoulder, elbow, and wrist complex as well when these patients come in. Patients do complain about being awakened with their symptoms. They tend to kind of shake their hand out a bit, like kind of falls asleep or what have you. This is known as a flick sign, and specifically if they're feeling these symptoms in the median nerve distribution and they're doing this at nighttime, it's a fairly indicative 93% sensitivity and 96% specific for carpal tunnel syndrome. So make sure when you're doing your history, we all know that a good history tells you most of the information that you need to know, and then you confirm that with your examination. In the later stages, when you start to have motor nerve involvement, then of course you'll start to see thenar atrophy and wasting and weakness. So every time a patient comes in and you're thinking carpal tunnel, make sure you do a full neurological, including dynamometer grip strength testing as well. We use that a lot to measure the objective progression of our patients if there's any weakness with carpal tunnel syndrome. So make sure you do that every week or so to follow up to see how your patient is coming along. And finally, in the very late stages, actually pain might actually completely disappear. Unfortunately, that's not a good thing because it implies permanent sensory loss and complete, basically destruction of the nerve. So it's definitely, something you want to avoid. And typically, that's pretty rare that would come into your office because these patients would be seen by specialists and so forth at that point. So summary overall with the symptoms, of course, know that there's a sensory disturbance. There can be motor weakness, so make sure you do muscle testing. And of course, in the later stages, make sure you're aware of any atrophy that's occurring in the thenar eminence. Make sure you always compare bilaterally in the hands as well to get an idea of what the opposite side is doing. Diagnostically, obviously, there's different ways to look at this. There's orthopedic tests like Phelan's and reverse Phelan's test, a straight compression test over the carpal tunnel syndrome, and Tinel's sign at the carpal tunnel as well. So these are all fairly good orthopedic tests to get an idea of what's going on with that median nerve. So remember that when you're looking at whether an orthopedic test or neurological test is actually good or you should be doing it, you're referring to sensitivity, which identifies those with the disease. So it's a true positive, as opposed to specificity, which correctly identifies those without the disease. So if you look at the sensitivity and specificity, say that 100 times over, Phelan's, Tinel's, and compression, you can see that the compression test actually has the best sensitivity and specificity for an orthopedic test. So let's take a little bit of the research. There's actually a fair amount of research on photobiomodulation or laser therapy and carpal tunnel syndrome. I do have to say that there is some conflicting evidence. So it's not all positive, but there have been quite a few systematic analysis and meta-analyses that give it a fairly good rating with respect to mild and moderate. So let's go over that. The first one I want to mention, and I'm assuming everyone can hear me okay because no one's mentioning that there's issues with the sound or what have you. This particular paper is the effectiveness of low power laser and kinesiotaping in the treatment of carpal tunnel syndrome. I found that interesting because I know a lot of clinicians are using kinesiotape, and it's just part of the routine for some clinicians. It's becoming extremely popular. So I thought this was a really interesting paper to include in the discussion. So this particular paper assessed and compared the effects of laser either with kinesiotaping or without, as well as sham laser. And they looked at functionality, pain, muscle strength, EMG parameters, and so forth with patients with carpal tunnel syndrome. So group 1 had laser therapy only. There were 21 hands being treated. Group 2 had kinesiotaping and laser therapy. And group 3 was just sham laser, 21 hands in total. So they were assessed by a visual analog or numeric pain scale, hand grip, finger pinch testing, the Boston Carpal Tunnel Syndrome, and a questionnaire, as well as motor and sensory nerve conduction at baseline, 3rd and 12th week as well. Sorry, 0 and 12th week. The laser that they used, interestingly enough, was a red wavelength, gallium aluminum arsenide, 27 milliwatts, 10 cycles per second. So they were pulsing it. That's also interesting. I should mention that there's some research to indicate that if you're treating nerves, lower frequencies like 10 hertz, 30, 20, 40 in that range seems to be more effective. So keep that in mind when you're treating nerves. They held it for a whopping 231 seconds per point. And mainly that's because it was fairly low power. A total of 10 joules applied over the area. They did 15 treatments. They were performed over 3 weeks, 5 days a week. Just a refresher, a reminder that we actually manufacture a red probe. It's called an LDR 100. So at 40% power, it would be roughly equivalent to what was used in this particular paper. If you don't have a red probe and you've been using BioFlex or thinking about getting one, I actually do recommend it. We find it helpful for pain because it really does a good job of saturating superficial nociceptors, but it's also, as you can see here, it can be very effective in superficial nerves as well. So the kinesiotaping material was adhered to the wrist with 30-degree extension, forearm supination, extension of the elbow, with some moderate stretching across the entire median nerve. So this kinesiotape was renewed or put on fresh every 2 days. I think they indicate that they obviously, if they had to, they shaved the hair in the forearm as well. So let's look at the results. There is a laser therapy group, that's group 1, the laser therapy and kinesiotape, group 2, and the sham laser in group 3. So baseline, the VAS or the visual analog scale out of 10 they all averaged about 6 out of 10. And then you can see the progression 3 weeks after treatment. The laser therapy group and the laser plus kinesiotape went down to 1, whereas a sham laser had a moderate placebo effect going down to 5. And then you can see at 12 weeks, roughly about the same, although you can start to see it creeping up a little bit of the pain in group 2. They also did a visual analog scale for nighttime pain, which again makes sense. It's a little bit worse in these patients at baseline, and you can see quite a dramatic decrease with laser and or kinesiotape, a much less decline with the sham laser. And then you can see the nighttime pain actually completely disappeared by 12 weeks in the first two groups and was still prevalent to a high degree in the sham group. I'm not going to go over everything, but I do want to mention the motor testing. So if you look at that, you can see the baseline finger pinch strength, and you can see a slight improvement over 3 weeks and over 12 weeks of treatment. And then the hand grip, similarly, you can see, I do have someone that mentions, when am I starting? So hopefully I have, everyone can hear me. Just type in that you can hear me, because someone is indicating that they're not even sure I'm starting. So you can see the hand grip strength, again, slightly increasing over time. And you can see what was interesting is that it declined a little bit after 12 weeks. So it may make sense actually that you may need to prolong treatment than what this research has shown. So they concluded, obviously, that low power laser therapy plus kinesio taping was effective and reliable treatment option within the clinical parameters that were tested. Another paper I want to discuss is the effectiveness of low-level laser therapy on carpal tunnel syndrome, and it was a meta-analysis. So they looked at 7 randomized clinical trials that met the inclusion criteria. Overall, it was 270 carpal tunnel wrists that were in the laser group and 261 that were in the control groups when you look at all the papers together. And I'm not going to go into details with this paper, but because they analyzed 7 papers, they concluded, once they did their statistical analysis, that low power laser improved hand grip, visual analog scale pain, STAP, which is a testing for carpal tunnel at 3 months of follow-up. And again, for mild to moderate carpal tunnel syndrome. They also recommended more high quality studies, obviously, to confirm the effects and to come up with appropriate protocols. Next paper, I do sometimes throw in laser acupuncture. I find it interesting because, I mean, I am trained in acupuncture, but you don't necessarily need to be an acupuncturist to add these acupuncture points. And so I want to actually just mention that. So for those of you who do acupuncture, it's straightforward. For those of you who don't, this is, I think, good information. You can actually add these specific points to your treatment regime. So they looked at 84 patients with carpal tunnel. They were randomly divided into either laser acupuncture or placebo laser acupuncture. LA is laser acupuncture. And they were assessing for global symptom score at baseline, 2 and 4 weeks. And the primary outcome changes were looking at any changes in this GSS as well as EMGs. They use class 3B lasers at 400 milliwatts. That's fairly high, class 3B laser at 810, so that's near infrared, 60 seconds per point. And specifically, they were treating 2 acupuncture points only, pericardium 7 and pericardium 6 on the affected side only. And these treatments were once a day for 5 consecutive days, followed by a 2-day break with a total of 20 sessions over a 4-week period. So for those of you not familiar, you can see where pericardium 7 is. It's right at the wrist crease, just a little adjacent to and in between the tendon of palmaris longus and the tendon of flexor carpi radialis. Recall you can pop out the palmaris longus by opposing your thumb and your 5th finger, and that should pop out, so you can easily find the palmaris longus. So if everyone wants to try that right now, remember that that's how you locate that, and it's just adjacent in between that and the flexor tendon is where you find P7. And P6 is proximal to that, 3 Chun, which is, you can see sort of about 3 centimeters or so proximal, right in the same same line or midline as P7. Okay, so that's how you find these points. And they found, and I'm not going to go over the details like I did the previous study, but they found that laser acupuncture may be more effective than the placebo for the treatment of mild to moderate idiopathic carpal tunnel syndrome in terms of subjective measurement. So not a great study because it was a lot of subjectiveness. I think they did some EMGs, but anyway, it was actually, a good paper to show that even laser acupuncture, you can get results. And those of you who do only acupuncture, adding laser acupuncture to the mix allows it when patients don't want to be needled, or or perhaps there's a contraindication or what have you. Okay, so let's talk a bit about using our equipment for treatment of carpal tunnel syndrome. Generally speaking, we will focus on using wrist protocol placements. We usually is wrap around the wrist in A, and we probably also do a perpendicular one to get into the palm as well, and sort of overlap the carpal tunnel area as well too. Someone asked a question about what a sham laser is. A sham is a placebo. So basically, a sham laser would be, it looks like it's turned on. If it's a red laser, then the wattage is extremely low, like maybe, I don't know, 1 or 2 milliwatts. So you can see the red light. Think of it like a laser pointer. You can see it, and patients think there's something going on, but there's so little energy that it won't cause any physiological effect. In the case of near infrared sham laser, it will look exactly like the regular laser, except that there's no light coming out. So basically, you usually see a little light goes on for your probe or whatever it is you're using, indicating that the light's on. So it looks exactly the same, except there's no infrared light coming out. That's what a sham laser is. Okay, so our protocol for the wrist, you can see here it's 8 minutes of red, continuous wave for the dual red array, excuse me. And then for the infrared, it's 10 minutes, so a fairly lengthy time frame. We pulsing it out, so it's 10 hertz. Again, 10 hertz is a frequency often helpful for peripheral nerve or nerve repair, and 40% duty cycle. So that's basically 40% of the maximum power. That's what duty cycle controls. And then the laser probe for the infrared is set to 40% power. It's that continuous wave. Total of 6 minutes, and that 6 minutes is spread out over the entire wrist, with a focus, of course, over the carpal tunnel. Now, I'm going to suggest that if you're treating carpal tunnel, that you can customize the protocol. So what we found to be quite effective is we split up into 2 placements, and we do 6 minutes of red. You can see here on the far right, which is sort of parallel to the wrist, and then we'll also wrap one around the wrist itself, and then we'll also do the infrared, the same kind of placements at 10 hertz, 40% duty cycle, same time frame, 6 minutes and 6 minutes. So it gives you about 24 minutes of total energy, a little bit more than the standard wrist protocol, but it's being spread out over the palm, the thumb, and any affected fingers, and the wrist itself. And similarly, 40% duty cycle, or 40% power, I should say, for the laser probe. And then you can graduate the protocol. If the patient plateaus or isn't responding, you can start pulsing out the red light, keeping the same placements, and slightly increasing the frequency, although still relatively low, and altering the duty cycle, giving you more energy, and eventually graduating to 100% power of the laser probe itself. And then the higher end of that would be to increase the infrared up to now 50 cycles per second, keeping it still 80% duty cycle. And then a final stage, again, if they're plateauing or you need to increase it even more, you can see that we really ramp up the frequency up to 250. Now, again, I've been talking about low frequencies, but we do find the higher frequencies, when the tissues have accommodated, seem to be a little bit more effective. And you can also drop down. So if you've been going at a high frequency, you may also drop it back down to that original 10, 20, 30, or 40 hertz as well. So Remember that when you're treating carpal tunnel syndrome, the treatment plan isn't just for a few weeks. You're gonna have to lay out probably 3 times a week for several months. Remember that when you're using a laser probe, it should be perpendicular to the tissue to ensure that all of that light is going into the tissue and minimizing any reflection as well. As a reminder, we're P6 and P7 if you want to add that. However, I would also recommend that you treat the entire carpal tunnel, so between P6 and P7, and of course along the length of the median nerve and along the branches of the median nerve into the thenar eminence and the thumb, into the second and third and fourth fingers as well, because all these branches will be affected. So by the time you treat all these, including these 2 acupuncture points, you should find that fairly effective. So severe cases of carpal tunnel obviously have a poor prognosis and probably, to be honest, aren't going to really respond well to laser therapy, so keep that in mind. If a patient is not responding after increasing the parameters, you can also look to treat the cervical spine in stage 1 on the affected side, with an emphasis on treating the C5 to T1 nerve roots, which of course form the median nerve. Initially, we recommend treating a patient consecutively, maybe 3 or 4 days, once a day, and then thereafter every other day, or like a Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday kind of thing, until they start to make a pretty good progression, and then you can slowly reduce it down to twice or once a week. So a typical treatment plan for mild cases, like I'm talking very mild, maybe 10 to 15, probably closer to 20. Moderate cases, I think you're probably at 20 plus, 25, 30 types of treatments. So it's going to be several months of treatment. So the patient needs to be aware of that. And remember that you're going to be subjectively and objectively measuring any change of the symptoms and make sure that patient's on board with understanding what they need to do ergonomically at home as well, or at workplace or what have you. So don't forget to address these underlying causes, whether it's ergonomics or systemic diseases, that kind of thing is all quite important.